गुड मॉर्निंग सुरेश रमेश कैसे हो तुम लोग हैप्पी दिवाली मॉर्निंग सर हैप्पी दिवाली हैप्पी दिवाली sir thank you sir you have the first patient Miss Kavita she is 45-year-old female known type 2 diabetes she is on insulin but she is not taking it regularly she came with the complaint of vomiting abdominal pain altered sensorium since yesterday sir and there is no history of fever chest pain and diarrhea vomiting abdominal pain altered sensorium it can be DKA right you suspected of that. All right. So first tell me why you asked for this fever, abdominal pain and diarrhea. Sir, to look for the precipitating causes, sir, like infection, MI or gastroenteritis. Exactly. Got it, Ramesh. Learn from Suresh. That you must always know why. Okay, then only you can tell, or actually, why is more important than what in medicine. All right, always remember that because if it's fever, you can suspect sepsis as an infection as a source of decay because infection triggers decay, right? Then if it's chest pain, then can be myocardial infarction because that can also trigger. Or if it's diarrhea, then dehydration because that can also trigger decay, right? Okay, Ramesh, you are first year, right? First, tell me what is the definition of decay? It's hyperglycemia, ketosis, and metabolic acidosis. There is right. Good, but I want you to be more precise. All right. Remember that if plasma glucose is more than 250 milligram per deciliter, blood pH or arterial pH is less than 7.3. That means acidosis is there, bicarbonate less than 18 is there, and there is a positive serum or urine ketones, and it should be not small quantity, it should be moderate or large quantity. And there is, if obviously along with that, there should be raised anion gap also. So that tells us that this patient has diabetic ketoacidosis. All right. So sugars are high, pH is acidotic, even bicarb is less, and ketones are positive. Got it? Now, Suresh, tell me if this patient had sugar more than 700 milligram per deciliter, pH was let's say 7.35, there were no ketones and altered sensorium was there, then what could have been the diagnosis? Sir, that's HHS, hyperosmolar hyperglycemic state, sir. Correct. Remember, DKA is acidotic and HHS, that is hyperosmolar hyperglycemic state, is hyperosmolar condition where there is more dehydration and altered mentation. Typically, HHS is seen in type 2 diabetes, whereas DKA is more classic for the type 1 but can also be seen in the type 2. Alright, and remember both of this kill through dehydration. So, first your focus should be on hydration of the patient. Okay, now Ramesh, you are junior, right? So, tell me about the pathogenesis. Sir, glucose can't enter the cells because of insulin deficiency and insulin resistance. So blood sugar rises. But what next? See, when insulin falls, the counter-regulatory hormones like glucagon, cortisol, catecholamines, and growth hormone, they all go up. Now, what happens when the counter-regulatory hormones go up? They can increase the blood sugar, and that causes hyperglycemia. And already, this patient has hyperglycemia. There is a reduction in the glucose uptake. Why? Because the insulin is not there, right? Insulin moves the blood sugar into the cells. But if insulin now is there or insulin resistance is there, then glucose uptake reduces. So there is increase in the blood glucose also. But body can't utilize that glucose. You got it? Body can't utilize that glucose. So body thinks or liver then gets activated and it thinks that body needs more glucose. So the liver causes gluconeogenesis. All right. So liver increases gluconeogenesis. It increases glycogenolysis, and again the blood sugar increases. All right. And now there is so much of the blood sugar that causes osmotic diuresis. Why? Because the osmotic pressure will increase because there is a more sugar in the blood, right? So it draws the water from your blood and then it gets excreted from the kidneys, and that causes dehydration. Okay, so this is the mechanism. You got it? So glucose uptake is less because of insulin deficiency or insulin resistance is there. Then gluconeogenesis triggers by the liver. Even it triggers the glycogenolysis. And there is one more feature I'll tell you next. So because of increase in the gluconeogenesis, glycogenolysis, osmotic diuresis occurs and dehydration occurs. Got it? But apart from these, now body needs energy, but body can't consume glucose. Why? Because there is insulin resistance. Then liver activates the ketosis, or it activates the breakdown of the lipids. So there is an increase in the lipolysis. That increase because of the lipolysis, there is a free fatty acid production, right? Then of these free fatty acids, the metabolism occurs. We call this reaction as beta oxidation. You must have learned that in the biochemistry, right? So these free fatty acids get break down, and because of that, two ketones bodies are formed. The number one is beta hydroxybutyrate and second one is acetoacetate. Okay, so beta hydroxybutyrate and acetoacetate causes metabolic acidosis. Got it? So dehydration is there, hyperglycemia is there, and metabolic acidosis is there, and that's your DKA. Got it? Now Suresh, you are the senior one, right? Tell me, why does beta hydroxybutyrate dominate in diabetic ketoacidosis and not the acetoacetate? I think, yes sir, because sir, NADH and NAD plus ratio is high in hepatic mitochondria and that favors the beta hydroxybutyrate formation, sir. Excellent. And Ramesh, this is how you answer in the MD Viva also. Like biochemistry, physiology, medicine, pharmacology, everything should be, put together. Thank you, sir. All right, Suresh, now tell me what are the common triggers for diabetic ketoacidosis? Yes, sir. Sir, we have 5 I's for that. Infection, insulin omission, infarction, that is your heart attack, intoxication, and initial presentation of diabetes, sir. Perfect mnemonic. And remember, infection is the number one cause, okay? It counts almost 40% cases of diabetic ketoacidosis. Got it? Right. Now, Ramesh, tell me, what is the typical presentation of diabetic ketoacidosis? Sir, polyuria, that means frequent urination, polydipsia, increased thirst, weight loss, vomiting, abdominal pain, fruity odor, sir, and maybe altered mentation like drowsiness. Good. And that fruity smell comes from the acetone. Remember this also. This can also be asked in Viva. Now tell me, just because we are discussing about the breathing patterns, tell me what are the other breathing patterns you know about? Ramesh, yeah, it's a basic question. Sir, we have Cheyne-Stokes, sir, which can occur in heart failure, fluid overload. And then we have Biot's, sir, which can occur in Pons or brainstem injury. Apneustic, sir, again, medulla injury, sir. All right, now let's start with the investigation. Tell me what investigation will order. I'll order, sir, ABG, electrolytes, X-ray, urine culture. See, first we have to confirm the diagnosis. For that, we have to ask for the random blood sugar, which should be more than 250. Urine and serum ketones, which should be moderate to large quantities. ABG pH should be less than 7.3. And HCO3 should be less than 18. Got it? That will confirm the diabetic ketoacidosis. Now assess the severity. So if pH is very severely low, then it's a severe diabetic ketoacidosis. Like pH, if it is less than 7, that's a severe diabetic ketoacidosis. All right. You should also quantify the acidosis, that if it's high anion gap or what. Okay. So you know the anion gap formula, right? Sodium minus chloride plus bicarb. And if it is more than 12, then that's a high anion gap metabolic acidosis. Simultaneously, you should also investigate for the electrolytes because sodium might get little low because of the hyperglycemia. Now, in this all patients, as I mentioned, the common cause of the DKA precipitation is infection. So for that, we should do CBC, urine, if you suspect urine culture sensitivity, I mean, if you suspect UTI, because that's also very common in females and diabetic patients particularly, because osmotic diuresis is occurring and a lot of sugar is there. So the bacteria found the environment very helpful. Got it? If you're suspecting LRTI, get chest X-ray done and blood culture done. If you're suspecting sepsis, all right. Even CRP, ESR can also give you, procalcitonin can give you idea about the sepsis. Now, if you're suspecting myocardial infarction, obviously ECG you can do, troponin you can do, and ECG anyway we have to do because in this patient the hypokalemia is very common. So even like we are gonna give the insulin as a therapy, so that can cause hypokalemia because of the intracellular shift of the potassium. So first we always check for the potassium range, and on the basis of that the treatment also varies. All right. And lastly, the osmolarity. So because if osmolarity is more than 6, like osmolarity is more than 320, then HHS is there usually. Okay. In diabetic ketoacidosis, osmolarity is not that high. Okay. So that's about the investigation. Okay. So now let's start with the management. All right. Suresh, outline the management, please. Start with the priorities. So in management, we follow FIK protocol, fluids, insulin, and potassium. Now fluids and insulin can be given together also. And then we treat the trigger. Good. That's a FIK formula. Okay. Fluid, insulin, and potassium. FIK formula. Please remember when you are writing exams also, Ramesh. FIK. You should remember. F is for fluids, I is for insulin, K is for potassium. All right. Let's go one by one. Fluids, we have to start with 0.9% of normal saline. And remember the dose, 15 to 20 ml per kg. About 1 liter we have to give in first hour. In the next hour, if corrected sodium is more than 135, That means there is a chance of hypernatremia. Then we give only 0.45 NS. Why? Because NS has more amount of the normal saline has more amount of the sodium. So we give 0.45% of the saline. Okay. And if the sodium is not more than 135, then you can continue the 0.9% saline as well. Okay. And there's one more point over here. While giving the fluids, if you feel that patient sugars are getting down, okay, like if it goes less than 250, make sure you add a 5% dextrose to 0.45% of saline to prevent the osmotic demyelination, because the brain is already acclimatized to the high blood sugar, and if suddenly sugar goes down, then again that osmotic demyelination and all can occur. Got it? So that's why we gradually reduce the sugar, because brain is habituated to the high blood sugar. And remember, in this patient, the fluid of choice is normal saline. Ringer's lactate can be avoided because it is associated with hyperkalemia and some level of isolysis also. Okay. Now tell me why we start with the fluid first and not insulin. Nowadays the treatment is, you can give both, but the old literature says always start with the fluid first. Why do we think that? So we give fluids because perfusion must improve, sir. Otherwise, if you give insulin, it won't reach the tissues. That's why first focus on the perfusion and then on the insulin. Exactly, because insulin without volume is disaster. All right. Now, second is insulin therapy. So before giving insulin, as we know, it causes hypokalemia. We should always check for the potassium. So if potassium is more than 3.3, start regular insulin at 0.1 unit per kg per hour. Please remember those 0.1 unit per kg per hour. For example, if I am 60 kg, so 60 into 0.1, that's 6 unit per hour I'll give. Okay, an expected fall in blood glucose should be 50 to 75 milligram per deciliter per hour. And अगर glucose less than 250 हो गया तो क्या करेंगे? Exactly, glucose add करेंगे. Okay, we will start 5% dextrose with our 0.45 NS. All right, and जैसे ही पेशेंट ओरली कुछ फूड लेना चालू करता है and pH starts to settle to normal, like more than 7.3, bicap gets more than 18, anan gap कम हो जाता है, then we will switch to subcutaneous boluses. I hope you understood. Now tell me, when do we never start insulin? So if potassium is less than 3.3, sir, because that can trigger the arrhythmia. So if potassium is less than 3.3, we have to hold insulin, okay, and give potassium chloride first. 20 to 30 milliequivalent we have to give per hour. And remember, through the central line only, through the peripheral line, only around 20 we can give per hour, okay? And if you have central line, maybe around 40 we can give, but not more than that, because potassium is quite irritating. And if potassium now, if it's between 3.3 to 5.2, then we have to add again KCl plus IV fluid we have to give. Okay, along with the insulin, you can give the KCl. Simultaneously you can give. And if potassium is more than 5.2, you can directly give the insulin also. Got it? So this is how the treatment is for AFIK. Now tell me, when do we give bicarb? Sir, if pH is acidic, sir, still acidic? Exactly. Only if pH is less than 6.9 as per the literature. And the dose is 100 millimoles of bicarb in 400 ml of sterile water. Plus we should give KCl over 2 hours. Okay. Otherwise it is unnecessary because it can worsen the hypokalemia. Got it? Yes. And we should also give phosphate if it is less than 1 milligram per deciliter or the cardiorespiratory depression is there. Okay, so we can give potassium hydrophosphate 20 to 30 millimole in 500 ml over 6 hours. Got it? And lastly, we are forgetting very important step. Treat the infection or treat the trigger. Sometimes it can be infection, the 5 I's, right? Infection, infarction, insulin omission. Okay, so here we have to start antibiotics only if focus is found. Okay, if your CBC count is very high, then you should start. Usually, empirical sepsis coverage is not recommended for all. Okay, please remember this important thing. In acute pancreatitis also the situation is same. We give only fluids, antibiotics is not given. But in case of upper GI bleed or in case of ascites, prophylactic antibiotic has to be given. This has been asked in so many exams also. Okay, so now tell me, how do you monitor the progress? We monitor with RBS, ABGs. Exactly. So RBS we should do hourly and target is 50 to 75 milligram per deciliter per hour we have to reduce. ABG we should do 2 to 4 hourly in the early, at least initial 6 to 8 hour, and then you can do gradually also every 6 hourly. Electrolytes also 2 to 4 hour. It's very important. Urine output hourly you have to check and target it more than 0.5 ml per kg per hour. Okay, you have to also do vitals and neurological status so that the patient's whatever dyselectrolytemia or hypoglycemia should not happen. Got it? So according to the American Diabetes Association resolution criterion, if pH is more than 7.3, bicarb is more than 18, NN gap is less than 12, and patient is alert and able to eat orally. Or lastly, tell me what are the common complications? Hypoglycemia, hypokalemia, cerebral edema, ARDS, and thrombosis. Good. And why cerebral edema is mostly in children? So it occurs because if you reduce sugar so fast, there is a rapid fall in serum osmolarity, and that can cause fluid shift into brain cells and swelling of those brain cells, and it can cause problems. Exactly, and that's why in pediatric DKA we lower sugar gradually. Got it? Lastly, few questions. Tell me, why do we check NN gap instead of only pH? Sure, because NN gap reflects the unmeasured acids and confirm the resolution of the ketosis even when pH is corrected by hyperventilation. That's why we check for the NN gaps, where we can exactly get the idea of the acids, that if patient is actually having acidosis or not. Brilliant, brilliant. Okay, so let's sum up this metabolic mess. First, confirm the triad: hyperglycemia, ketosis, acidosis is there. Identify the trigger, the 5 I's. Then fluid resuscitation, we have to start insulin when safe, depending on the potassium level. Add dextrose when glucose is less than 250. Monitor ABG, electrolytes, urine, and stop IV insulin only after the gap closure or patient starts to take orally. Okay, so remember, DKA doesn't kill from diabetes, it kills from delay, dehydration, and deranged electrolytes. All right, team, good round. I hope you learned. Let's go to the next question now. Yeah.